There we go. Great. Good morning and good afternoon, everyone. Welcome to the webinar, Enhancing Community Health Research by Engaging CHWs as Research Partners. We have 90 minutes for this webinar today. We'll have about 45 minutes for presentations and an additional 40 to 45 minutes for questions and answers. Please put your question and answers in the Q&A function rather than the chat. We'll be managing our questions and answers from the Q&A. This webinar is brought to you by the Health Systems Global Thematic Working Groups for Community Health Workers and Health Systems Global Social Science Approaches for Research and Engagement in Health Policies and Systems Shapes. In addition, this is done in partnership with CHW Central. So there'll be more information at the very end of this webinar on how to connect with the Health Systems Global Thematic Working Groups if that interests you. May I have the next slide, please? It is my privilege today to introduce our moderator, Floribela Redondo Martinez. Floribela is the co-founder and executive director of the Arizona Community Health Workers Association, ASCHW. She is also the state-appointed CHW Advisory Board member for Arizona CHW Voluntary Certification, co-director for the C3 National Core Consensus 2-Phase Project, co-chair of the Arizona CHW Coalition, member of the National Common Indicators Project, and board member for the National Association of Community Health Workers in the United States. In addition to this accomplished career, prior to starting in these roles, Floribela served for 25 years as a CHW, a promotora, educating farm worker peers on HIV and STDs in the agricultural fields of Arizona and California. She also has over 20 years of training experience developing and implementing bilingual and bicultural community health worker programs. Floribela is a nationally recognized public health leader and advocate for voluntary certification path for CHWs in Arizona. And one of her passions is working and developing programs that build opportunities and strengthen the leadership of women in rural and underserved communities. So with that, we are thrilled to have Floribela as our moderator. I can't think of anybody better to guide us through this series of presentations on engaging CHWs as partners in research, not using them in research, but engaging them as partners. And with that, I'd like to hand it over to you, Floribela.
Thank you, Rebecca. Thank you for the invitation. I'm really excited to be here. So we all want to begin to hear our great presenters. So before we begin, just as a follow-up, we have a few housekeeping information. This webinar, as you may know, this webinar is being recorded. And if you're not speaking, please put yourself in mute. This webinar will be 1.5 hours long. We have 3 programs that we are really excited to hear about. And each of the program will have 15 minutes for their presentation. This will then be followed by questions and answers after we had all our presentations. So please submit your questions in the Q&A button in the bottom, and Rebecca, I believe, that's going to be managing the questions. So I would like to take a few minutes to briefly present our panelists for this webinar. Our first panelist will be Kara Kotler. Kara will be presenting on CHW's own health intervention research teams. Kara is a current PhD public health student in the Health Behavior Health Promotion track and minoring in family studies and human development at the University of Arizona. She is also a graduate research assistant with the CDC-funded Arizona Prevention Research Center, which primarily focuses on addressing chronic diseases, health disparities in Latino and migrant population within the border region of Arizona. With that, Kara, the floor is yours.
Okay, great, thank you. I'll just wait for the slides to pop up. But thank you to everyone for joining this webinar. Good morning, afternoon, or good evening, wherever you are in the world. It's a pleasure to be here. Okay, Great. So again, as Flor said, my name is Kira. I'm a research assistant with the Arizona Prevention Research Center at the University of Arizona, which focuses on CHW-led health interventions in the U.S.-Mexico border region. And the title of the presentation is CHWs and Health Intervention Research Teams, which will summarize the results of a scoping review we conducted examining the roles of CHWs within health intervention research. And next slide, please. So to start, we wanted to ground the presentation in some key definitions. So we utilized the American Public Health Association's definition of a CHW being a frontline public health worker who is a trusted member of and/or has an unusually close understanding of the community served. We also utilized community-based participatory research, or CBPR, as a framework to delineate the research process, and we examined the involvement of CHWs across CBPR and non-CBPR studies. So CBPR provides a framework to equitably involve community members, researchers, and other stakeholders across all phases of the research process, recognizing and maximizing diverse contributions. Next slide, please. So within the US, CHWs are becoming increasingly incorporated in health intervention research to address health disparities. And recently, a CHW advocacy group identified research as a key competency of the CHW profession due to the fact that CHWs possess critical assets and skills as leaders within their communities to advance health research. But it has really remained unknown the extent to which CHWs are engaged as research partners, which was the main motivation for undertaking the scoping review. Next slide, please. So we centered our scoping review on 4 main questions. The first being what types of health intervention studies are involving and engaging CHWs as research partners, how frequently are CHWs involved across the phases of research, what is the nature of CHW's positionality on the research team, and how does the CHW involvement benefit health intervention research? Next slide, please. So after systematically screening a body of articles, we reviewed 130 health intervention studies conducted within the US, all published between 2008 and 2018, and involving CHWs to varying degrees. So within the primary analysis, we examined the types of study designs and the phases of research with CHW involvement. And then secondarily, in studies with high CHW involvement, which we defined as studies where CHWs were involved in 5 or more phases of research, we synthesized the benefits of CHWs to the quality of the research. Next slide, please. So turning to the results of our scoping review, this figure shows the percent of studies with CHW involvement in each phase of research. As you can see, it starts from identifying the research question, going all the way through to dissemination and action around the results of the study. And as you can see, CHWs were most heavily involved in implementing the health intervention, followed by participant recruitment and data collection. However, CHWs were least involved in the formative stages of study design, so identifying the research question from the outset, designing the intervention, and selecting measurement strategies, as well as research activities post-intervention relating to the data and the results. So as our analysis will show, we view these as lost opportunities to improve the rigor of the health intervention research project. Next slide, please. So regarding the characteristics of the studies, most of the health interventions involving CHWs were community-based participatory research studies, around 60%. Additionally, almost half were randomized controlled trials. And we did notice a difference in CHW engagement across CBPR and non-CBPR studies. So among CBPR studies, CHWs were engaged in a maximum of 9 phases. However, among non-CBPR studies, CHWs were engaged in a maximum of only 4 phases. So there was quite a difference in the range of CHW involvement. Oh, perfect. So then next, we also wanted to identify how CHWs benefited the health intervention research. And again, we examined studies with high CHW involvement, which we defined as studies where CHWs were involved in 5 or more research phases. And we performed a content analysis of the discussion to identify specifically how authors describe CHWs strengthening the intervention study. And we ended up with 12 overarching benefits, which really span the entirety of the research process. So in regards to the design of the intervention, CHWs were noted to increase the research team's awareness of the broader community context, specifically the social determinants impacting participants that could influence intervention delivery. And CHWs also greatly contributed to the community acceptability of the interventions. So an example of these two benefits came from a study of diabetes management among Bangladeshi immigrants, where CHWs adapted the intervention to be delivered remotely to accommodate participants who traveled back and forth between the US and their home country. And they also led the cultural tailoring of the intervention, which included the translation of materials, incorporating traditional cuisine, and also incorporating common culturally based beliefs regarding diabetes. So that example kind of illustrates the ways in which these benefits came forth through the scoping review. Next slide, please. We also found that high CHW involvement increased community engagement in the study. And this was due to the fact that CHWs utilized their broader social or kin networks for participant recruitment, and also negotiated the inclusion of structurally vulnerable communities in research, referring to communities subject to exploitation and research in other settings. And because of their connection with community residents, they really enhanced participant retention in the study through ongoing data collection and follow-up assessments. So one study which demonstrated these benefits was an intervention to address health disparities among Latino day laborers. And the community health workers who were part of a community-based organization already had existing connections with this population and knew them very well, which really aided participant recruitment. Latino day laborers are also a population that are frequently undocumented, and the CHWs adapted the intervention to the particular stressors the day laborers face due to their lack of citizenship and made them really feel safe enough to participate in the health intervention. Lastly, the study noted that CHW's rapport with the day laborers contributed to high participant retention and fidelity to the study over the course of the intervention, so there was very low attrition throughout as well. Next slide, please. Next, CHWs benefited research by maximizing the inclusion of participant voices in research. So CHW's deep relationships with communities facilitated the incorporation of community perspectives into the research, which is important in terms of making the intervention representative of community needs. And also CHWs validated the data based on their common experiences with participants. So these two benefits were illustrated by an environmental justice intervention where the community health workers did a survey of community residents to capture their stories regarding concerns over environmental exposures and childhood asthma, which the research coalition had not addressed previously. And it was decided ultimately that this would be the objective of the intervention. So CHWs were able to bring community voices forward and have those voices set the research agenda. And then the community health workers presented the results of the community survey at a city council meeting to enact policy solutions to environmental concerns, and also provided their own stories as mothers regarding high rates of childhood asthma to further validate the survey data and provide their common experiences with participants. Next slide, please. So next, health intervention research was also more impactful on individuals and communities with the involvement of community health workers. So participants benefited more from the intervention due to CHW's connections with community resources. And there were several examples of health interventions where CHWs leveraged their connections to link participants to needed services, which maximize the impact and health benefit of the intervention. Community health workers also encourage individual and community advocacy to enact sustained health promoting and individual system level changes. So CHWs worked with community members to identify priorities and mobilize to affect change, whether it be improving occupational safety or collaborating with policymakers to address health needs through local policy changes. And lastly, the increased capacity of CHWs created a lasting community resource. And what we mean by that is that community health workers through the research project cultivated leadership and research skills, which then were taken to sometimes new jobs within their community, or they were able to assume new responsibilities within their existing jobs. Next slide, please. And lastly, community health workers contributed to the sustainability of health interventions, which was really maximized when the research leveraged experienced CHWs whom were already embedded within community-based entities, and they could continue the intervention after the conclusion of the study and incorporate the intervention activities into their existing roles. Next slide. Thank you. So overall, the results provided some key implications for health intervention research teams. So first, the CBPR approach was more congruent with CHW involvement across the research phases. So we definitely noticed a difference in engagement of community health workers across CBPR and non-CBPR studies. CHWs were mainly responsible for the intervention implementation, participant recruitment, and data collection, which is not surprising given that these research activities involve direct interaction with participants, and community health workers innately possess strong connections with community residents. However, the lack of engagement in the formative and also later stages of research does not utilize CHW's full scope of practice, which presents lost opportunities for health intervention research projects as substantiated by the 12 specific benefits that we identified. So in the formative stages of research, CHWs are highly effective in tailoring health interventions to the target population, so they are more culturally congruent to participants, which ultimately is important for the retention of participants over the course of the health intervention. And also the insights of CHWs were beneficial to data analysis interpretation since they understand and have common experiences with study participants. So it would be an important component of data triangulation. So positioning CHWs as research partners would increase the quality and relevance of the health intervention study as substantiated by those 12 distinct benefits identified in the scoping review. There were various strategies described by the studies in positioning CHWs as research partners, which included from the outset, of course, taking a CBPR approach and also positioning them on decision-making bodies such as community action boards, so they can partake as influential stakeholders and direct the course of the research process. And also training was a very important element as well. Providing substantial training on research methods was important to allowing CHWs to fully engage as research partners as well. Next slide, please. So here we just provide the citation of the scoping review for reference, just in case anyone wanted to take a look at the full article. But otherwise, that concludes my presentation. So thank you so much.
Thank you, Kiara. Great presentation. The second panelist will be presenting on engaging CHWs in designing, delivering, and evaluating a supervision program. Our first presenter will be James Donovan. James Donovan is a practicing physician working in NHS and the head of division of research and health equity at Omni Med Uganda, working with community health workers to strengthen the health systems in Mukono, Uganda. He holds a PhD from the University of Oxford and was a former Kennedy Scholar in Health Equity and Human Rights at Harvard University. The second presenter will be Ms. Rebecca Hamala, which I am really excited to present. She is a CHW supervisor at Omni Med Uganda. She earned a degree in development studies from Macquarie University and has previously worked with Mukono District NGO Forum as an administrative assistant for 2 years. She joined Omni Med in November 2018 as finance officer and CHW supervisor and is responsible for overseeing the delivery of care in the communities around Sita Nasigo Parish. The third presenter will be Mr. Alan Soul Namanda. He is a CHW supervisor at Omni Med Uganda. He graduated from Kimbogo University in 2016 with an honors degree in development studies. He also holds a certificate in human resource management from Macquarie Center of Business and Management Sciences. Since 2018, he has supervised CHWs in Mukono District. With that, I'll turn the page to Dr. James Donovan.
Thank you, Florabella. Good morning, good afternoon, good evening, wherever you are in the world right now. We're really looking forward to the next 15 minutes where we're going to have a chance to discuss the findings of the role of community health workers in the design evaluation of a supervisory intervention in Mukono District, Uganda, which we've been doing for the past 3 years. As Florabella pointed out, this talk is going to be done in conjunction with Rebecca and Alan, who were integral to this project, and they're community health worker supervisors who do a fantastic job day to day. And so at the end of this talk, when we come on to the question panel, it'd be great if you could direct the questions towards Rebecca and Alan. So next slide, please. So just as a brief background to the research study that was carried out, this was a community-based participatory research project, as Kira put so nicely. It's a form of research that involves the communities that are being part of the research project. And this particular focus for this project was looking at ear disease in rural areas of Mukono district in Uganda. This was a topic that was highlighted as an important research concern by the community health workers, which again links nicely to Kira's study, where she showed that very few CBPR projects actually involve the communities in determining and framing the research question. Just as a brief background as to why ear disease is an important topic in low middle income countries, in 2013, a WHO report showed that 64% of participating countries from sub-Saharan Africa region had fewer than one ENT surgical specialist available per million population. And this is compared with 12 in some high-income countries. Similarly, there's a severe lack of audiologists and speech and language therapists. And within country variations, there's also issues, especially in rural areas, where traditional hospital-based models of care fail to reach the most marginalized populations living in remote or rural regions. Next slide, please. So one of the potential and proposed solutions to address this gap in human resources for health has been to task share and potentially task shift with community health workers and try and see if community health workers can deliver ear care. We conducted a systematic scoping review back in 2018, looking at the potential role of community health workers. And we found 38 studies from across low, middle and high income countries in resource poor regions that suggest community health workers have a role in the diagnosis and management of ear disease. However, it's unclear as to how many of those studies actually involve the community health workers in the process. And this was something that we tried to address in the present research study, which we're going to discuss today. Next slide, please. So as a brief background, the setting of the study was in Mukono district, Uganda, which is in central Uganda, relatively close in terms of geographic distance to Kampala, but it has a rural population, and the parish that we were working in was Satan Nazigo parish, which is in Nachasunga sub-county. There were around 50,000 people in the parish that we were working with. Primarily, it was a rural region. Next slide, please. So as part of the community-based participatory research cycle, there is an observe phase and a reflect phase. This is where you're trying to frame the challenge at hand. And this was done through a photo voice project. Photo voice is a particular research method which was first described by Wang and Burris in a seminal paper in the late 1990s. Essentially, you give the research participants cameras. They then go and take photographs of topics or issues that are of importance to them. And then those photographs act as discussion topics around the topic of interest. And in this case, it was barriers to healthcare in this particular region. So this was done between October and December 2018. And this is the first photo voice project, which I'm going to discuss briefly. Next slide. So the initial photo voice project looked at barriers to healthcare in the Mukono district, and a variety of issues were highlighted by the community health workers that were involved in this study. These range from access to care to issues around supply and equipment. And one of the issues that was also highlighted was a lack of training and supervision in ear disease, which was factored as a major disease burden in the local region. The photos then acted as prompts, and as you can see here, some of the photos were discussed at these focus group discussions where all the community health workers were present, and the photos acted as prompts. This was a really powerful way of visualizing some of the major health issues in the region. And if you're interested in reading this study in more detail, both of these studies are available open access through the journal Global Public Health. Next slide, please. So there were two important findings, as I've mentioned. Number one is that ear disease is a majorly under-recognised issue, and the community health workers felt that they didn't receive enough training to address the burden of disease. The second issue is that they felt that they weren't supervised appropriately to carry out their work-related duties. So Photo Voice was really important in highlighting one of the major research questions that was going to be addressed through this subsequent project. Next, please. Phase 2 of the cycle of community-based participatory action research was the ACT phase. It's really important that you act upon the findings that were highlighted by the communities in order to try and enact change. And this was done during January 2019. However, it's important to note that this ACT phase wasn't simply a one-off isolated event during 1 month. It was a continuing process, and that's demonstrated in this diagram through this embedded cycle where you iterate and act upon any of the changes that you find throughout the project. For simplicity for this project, we're going to just outline the initial ACT phase that was done in January 2019. Next slide, please. So there was training delivered to the community health workers who were all involved in the design of the initial training workshop. This training was informed by WHO primary ear care and training manuals, which were translated into Luganda. This was initially delivered over a 3-day workshop, which was designed with the key stakeholders, including local ENT surgeons, also local community health workers, parish leaders, and primary school teachers. It was delivered at the local health centre, and again was a mixture of lectures, practical sessions, video demonstrations, and observations of live demonstrations. And this was done in small group work, again, directed by the community health workers, and it was determined as to how they felt they would learn best. Next slide, please. Again, there was an assessment at the initial point of the workshop being carried out, and 6 months later, where the community health workers were assessed on delivering ear care services. And this was really as a competency assessment. And again, this was done through practical assessments rather than traditional multiple choice questions. And this again was directed by the community health workers as to how they felt they would learn best and how they felt their knowledge could best be applied in a practical sense. Next slide, please. There was also ongoing training and support, again directed and designed by the community health workers we were working with. This underwent multiple phases of iteration. However, for simplicity's sake, for this presentation, we'll just discuss the final version of the supervision, which was a mixture of in-person supervision and also WhatsApp-based supervision, so remote mobile facilitated supervision, where the community health workers were part of a collective group able to exchange hypothetical cases and day-to-day questions to enable ongoing training and support. Again, an area that was highlighted through the very first Photo Voice project during the observe phase. And again, this was an important part of acting upon the concerns of the community health workers and really taking those issues into account. Next slide, please. So the next stage of the action research project in terms of the cycle, we'd looked at observe, reflect, which was done through the initial Photo Voice project. We then acted upon these concerns, and then we implemented the program in the community. And this was a phase of evaluation and modification. We did capture the traditional forms of assessment, which were done through epidemiological surveys, as well as looking at various quantitative measures. One of the important things we wanted to do was frame this evaluation through the eyes of the community health workers and take a participatory approach towards the evaluation. And this was done through a next Photo Voice project, which Alan and Rebecca are going to describe in the next section of this presentation. Next slide, please. So very briefly, there was some community outreach work. So the community health workers went house to house visiting community members, which they were responsible for, and screening people for ear disease. So looking specifically for things like ear discharge. They take a brief history, do an examination of the ear using a low-cost otoscope, and they would also examine hearing through crude hearing tests. And then they deliver some treatment in the community if needed. If not, they would refer upwards to ear camps. These were again organised within the community with local ENT surgeons, and it was a way of bringing care closer to the community. Again, this was acting upon the concerns that were addressed, that were highlighted by the community health workers early on in the Photo Voice project back in phase 1. and this was a way of acting upon their concern. Next slide, please. So again, this is just briefly showing how management was affected. So the first stage, management was given in the community for simple disorders of the ear, which didn't require any specialist input. The next levels, level 3 and level 4, treatment was done at the local health centre by community health workers supervisors who received additional training. And level 5 was those serious disorders that were picked up, which needed review by an ENT surgical specialist. And these were done at ear camps held in the community with a local ENT specialist who would travel down once every 2 months and review patients. And then if patients needed listing for surgery or further audiological assessment, this would then be arranged. And again, this whole process was designed in partnership with the community health workers, how they felt care would be best delivered in the community. Next slide, please. So Alan and Rebecca are now going to give a brief overview of photo voice and how this played a role in evaluating the programme. Next slide, please, and I'll hand over to Rebecca and Alan.
Okay, thank you so much, James. Continuing with the presentation. So photo voice has really helped community health workers in capturing images from the community. So with photo voice, it allows the use of images, and people, a community health worker can be able to tell stories around the image. And in case of the disease, and the community health worker can be able to share with the patient, like what caused the disease and how long has it taken, or whether the patient has sought medical assistance. So photo voice allows all that. You can talk about an image and it can give you all the details of what needs to be done for the patient. Also, photo voice can also help in knowing the use of images or understanding the disease. So once you take a picture, you really know what disease is the person is talking about as far as the research is concerned. Let's move to the next slide, please. Yeah, so still on photo voice. So during the ear camp training, it helped us to identify the various issues. So with photo voice, a community health worker is able to differentiate between the different ear defects. So you can be able to see what disease and how it appears to be. So for example, in the first image, the post-auricular fistula, so with an image, a community health worker was able to see exactly how the auricular fistula looks like, and it's like a birth defect, and which they should understand. So if it comes to microtia, it's the same issue. So photo voice helped us to train the VHTs or the community health workers to understand better how to differentiate between the diseases and how to report a case or to draw down, write about the history on the case and give the exact information about the patient. Next slide, please. Yeah, so with photo voice, continuing, it also allowed us to get different perspectives from the community. So as we shared with the community, you'd hear people have different beliefs, and people have what they seem they know that can help to cure the ears or any other specific disease. So you may find someone who is not well conversant with going to the health center to get medical assistance, and when the person is maybe using other means of medication, maybe local medication and other medications. So it allowed us to share different cultural beliefs and interact with the different people in the communities and to know what they think is best for them. Yeah, next slide, please. So during photo voice, we also understood like people. So last year, okay. Sorry.
Okay, thank you very much, Alan and James. So during that photo voice project, we discovered a lot of things like how socioeconomic deprivation influences prevalence of disease and prioritization against competing needs. In the first image, we can see a madhouse, and in that madhouse, the community health worker explained that it holds like some insects, and once these insects enter people's ears, they get like some complications, and once they treat this complication, it cannot go away the next time because that particular house is still not solved. So in here we look at how such houses can cause like certain diseases, and like once they are not getting like good houses, the problem won't go away. That means like the community health workers still have the burden of treating these people every now and then. So in the next image, we look at a pig, and in this pig, the community health worker who took that particular image said that most homes own such things like pigs, like cows, but then like you find they only have only one, and on that particular animal they rear is not enough, cannot like give them enough money to treat certain diseases, especially if it involves surgery. Surgery is quite expensive, and most people who own such things cannot afford it, which is like a problem of community health workers, because these people look up to them. They see them as their soul saviors. Next slide, please. So also during photo voice project, we noticed some limitations. For example, most of the people in those villages, once they see you with a camera, they think you're trying to take their photos to use them. And once they realize the project involves fights, in Uganda we call them bazungus, they become more conscious. They think that maybe the bazungus are going to use their photos to gain money from them. Also, some of them like declined, saying like, they are not sure where their photos are ending up. So like the trust is really limited when it comes to photo voice project. Next slide, please. So that is just me talking about photo voice project in general. So maybe you can take time and listen to that.
Photo voice project involved use of photos to document, analyze, and reflect on certain aspects of the community. In our case, focus was on the health aspect. I personally had very little knowledge about photo voice prior to the project with the community health workers. But the more I continued to learn about it, the more interesting I found it. I acquired so much knowledge and became more aware of my surroundings. I realized there is so much I didn't know about my community through photo voice. There are things I used to see or hear about but didn't realize how impactful they were. Photo voice also increased my community engagement. I got to interact with a lot of people, and it gave me the opportunity to voice their opinions. There is also a high possibility that their photos will reach policymakers so that their needs are addressed. The biggest disadvantage I noted with photo voice was the difficulty in building community trust. Once people see you with a camera, it raises so many questions. They keep wondering why you're taking their photos, where their photos are going to end up, whether you're trying to use them, and they need to be very, very convinced for them to be comfortable in such scenarios. I would recommend community health workers who are interested in photo voice to go ahead and do it. But before they do it, they should carry out a needs assessment. The needs assessment will enable them get to know what exactly that particular community needs before the start of the project. They should also try to find out the culture of that community. Once they get to know the culture of that community, they will find the best approach to get to interact with those particular people. It also makes the people very comfortable when they are airing their opinions. Thank you.
Okay, thank you all.
So thank you, Alan and Rebecca. I think they really amazingly articulated the strengths, benefits, and also potential limitations of photo voice. This can't be seen as a silver bullet solution. there are limitations, especially ethical limitations of image capture. And I think it's really important to reflect upon that if we're to take on this method in future. Just briefly like to finish by acknowledging all of the community health workers that were involved in this project, especially Rebecca and Alan, but also the rest of the community health workers that were involved, all of the funders who made the project possible, and all of the ethical review boards that reviewed the project. Next slide. And yeah, we just want to thank you all for attending today, and Alan and Rebecca will look forward to addressing any of the questions that come up later on. Thanks again for having us.
Thank you. That was a great presentation, and I invite everybody to please continue to put in your questions in a question and answer chat, and Rebecca will be taking care of those, and we'll bring them back at the end of presentations. Our third panelist will be presenting on CHWs as core researchers to understand health services delivery for people affected by severe stigmatizing skin diseases in Liberia. Hannah Berrien is a research fellow with Red Dress, a research study seeking ways to reduce the burden of severe stigmatizing skin diseases in Liberia. Hannah's area of expertise at Red Dress is patient engagement and person-centered approaches. As part of this role, Hannah worked along with co-researchers, including CHWs and persons affected by SSSDs, to collect data using a variety of methods, including photo voice and big nets, to better understand the patient pathway for persons affected by SSSDs. The second presenter will be Sarah S. Coley. As a community health services supervisor, she is one of the peer researchers working with Red Dress in Lofa County, Liberia. Sarah has an associate degree in nursing and certificate in teaching, and has been working in this position since 2017. The third one is Anthony Corbelay, is a community health assistant, Shaw, in Lofa County, Liberia, and is one of Red Dress Photo Boys co-researchers. He has worked as general community health worker since 2010 and a community health assistant since 2017. With that, I turn the presentation back to Hannah. Hannah?
Yes. So are we presenting or using the audio? Hello?
You can
So
present.
Hannah, we have your audio. It's the last slide of your presentation. Did you want to start with that?
Yes, so I'm going to do the presentation, right?
Yes, please start.
Okay, thank you. So good afternoon, everyone. My name is Hannah Berrien. I'm a research fellow for Redress Liberia. I'm going to present on community health workers as co-researchers to understand health service delivery for people affected by stigmatizing skin diseases in Liberia. Next slide, please. So this is the outline for our presentation, where we have overview of redress, person-centered approaches within redress, how people are affected by stigmatizing skin diseases, our preliminary findings, and discussion with our community health workers. Next slide, please. Quickly to begin with this presentation, let us reflect on the aim. Are we there? Hello?
Hi, sorry, Hannah. She seems to be having a little bit of difficulty getting presentation view. I think she'll just reload it.
Yes, so I was just trying to do the presentation since we can get to the recording.
We can get to the recording if you wanted to start with the recording. Is that what you wanted to do?
No, I thought you were finding it difficult to play the recording, so I was just going ahead with the presentation.
Okay, we can go ahead with the presentation and you can get to the recording at the end.
So I can play the recording from my end, so if you can help me to play for your end, it will be fine for me. So if you're finding it difficult to play, I could do the presentation. Hello?
Hi, Hannah, sorry. Janine, do you want Hannah to present the recording, or do you want to just load up the recording?
Hi, Hannah, please load in your recording, please. Or present, rather. Sorry, thank you. I have created it so you can share screen from your computer if you like.
Jenny or Rebecca, can you help me to share screen from your computer, please, with my audio? I will just present from the slide. Or Rosie, you can do that for us. Okay, thank you.
Thank you.
I can go ahead, right?
Yes, please.
Okay, thank you. Can you hear me?
Yes,
Yes, we
hear.
can.
Okay, sorry. So I would just like to quickly reflect on the aim and approaches which Redress seeks to achieve and use throughout our study. So we have reducing illness, stigma, social exclusion, and poverty through person-centered approaches. So focusing on patient person-centeredness will also involve protecting and listening to community health workers, particularly those working within a community where they are shaping decisions about the way healthcare is being provided. And this is why we Redress, we have sought to include health workers, particularly those at the community level. So this slide is quickly telling us the different diseases that Redress focuses on: leprosy, lymphedema, hydrocele buree ulcer. Next slide, please. So community health workers and persons affected by severe stigmatizing skin diseases, participation is key to Redress. And as such, during Redress proposal development, patient advocate was involved, people affected by stigmatizing skin diseases and their family, they were all incorporated into our proposal design. And as such, during our implementation as well, we recruited people with severe stigmatizing skin diseases and community health workers as peer researchers, where community health workers as well, faith healers, traditional healers participated as co-researchers through photo voice method, which is one of our participatory methods. And photo voice co-researchers, including community health workers as well, also involved with our analysis. Next slide, please. So these are our research team. These are our research team. And in order to achieve the objective or Redress, we use participatory approaches. And through the participatory approaches, we had the involvement of our peer researchers, including persons affected by severe stigmatizing skin diseases. And two of our participatory methods that were used was VNet and photo voice. Next slide. So this is Redress engagement with our peer researchers. There was recruitment. They were recruited from the County of Data Collection. We held training with them to build their different skills, and they fully participated in the data collection, and we held regular debriefing and supervision with them. And we anticipate that they will be involved with the analysis process. Next slide. So like I said earlier, these are the two methods that were used for redress participatory, VNet and the photo voice. The VNet was held with Black beggars, traditional healers, faith healers, where we wanted to explore routine management of severe stigmatizing skin diseases. And the photo voice was held with community health assistants, community health volunteers, faith healers, traditional healers. So we wanted to explore current treatment practices, motivation for their work, and understanding of mental health and stigma. Next slide. So this is our photo voice process. For the photo voice, it was held with community health assistants, community health volunteers, traditional healers, and faith healers. So there was an initial training with the different participants, and onward, we held one-to-one visit with them in their different communities to review the different photos that was taken by them. And in our final photo voice workshop, they worked together to group photos according to theme. And there was a discussion to agree upon the different themes that were developed by them. Next slide. So these are some of the key findings from our photo voice method. Community health assistants and community health volunteers, they expressed delay in payment of incentives. They mentioned farming is a means of survival for them. Provision of motorbike will help them to cover long distances. Network was mentioned as a challenge for them. And there were few recommendations that were mentioned by the different participants. They talk about monthly supervision to track their progress. They mentioned training on how to identify people with stigmatizing skin diseases in the community. They needed job aid that could be used to identify priority diseases or severe stigmatizing skin diseases in their community. Next slide. So these are our community health workers. Will listen to the recording for them. Thank you.
Hi, Rosie. If you're sharing this presentation, we need to share the audio. The participants can't hear the video. So in the share screen, you have to share the audio as well. And then you'll probably need to rewind to the beginning. Still no audio.
Recruited in training. I am pleased to introduce Sada Esquadi,
and Anthony Kovade, who are CHW in Lofa County. They were recruited and trained in Lofa County as peer researchers. So I would like you to please share your experiences as co-researcher. What did you learn as co-researcher?
All right, thank you very much. I learned a lot. I did photo voice, I took photos, I recorded audio, and I also did supervision. I keep confidentiality.
All right. On that, I did a focus group discussion and note taking, consent form, how to take consent from people before everyone and statement. Then photo voice one-to-one visit.
How did you find the process of participating?
Yeah, I found the process. I learned a lot of research skills, building community, personal capacity.
I understood what stigmatization means of people like carrying this disease and where we stigmatize them and it can actually be a stigma only. And it was a good, I learned how to keep a barrier and it was very participatory.
So what does participation mean to both of you?
Participation means to me respecting the strength of everyone, including community members such as people affected by triple SD. Also, fifth healer. That means strength interacting with everyone and learning and working together.
All right. It also means of giving an ownership to people building capacity of everyone. Give up ownership to the community members so that they will take the lead. And it means finding solution together like redress.
Okay, Anthony, you talk about photo voice. So how were you doing the photo voice and how did it go?
Yeah, I did the photo voice by taking picture. And during the taking of the pictures, I did a consent form, and which is permission was taken. So I did my photo voice through the phone.
Thank you. So Sada, you talk about VNet. Can you share your experience with VNet? How was it?
Yeah, then we put a group of people together. A group of 7 or 9, we put them together. We ask them, we take a short story, we read it to them, and we ask them about their view towards that story. What they understood from the story, the day they meet up with that patient, what would they do for that patient, and we discuss it together.
Okay, you also talk about one-to-one visit. So can you share your experience with that one-to-one visit as well?
Yes, one-to-one visit, we go to participants in the field and we take the phone, the pictures they took, we ask them how they felt when they were taking a picture, what the picture is meaning to them, they will explain everything to us, and we also ask them for the consent form. Because in everything you have to get permission from everybody before you can go ahead and do anything with it.
So also like you to share your experience with consent taking.
Okay, in consent taking, and those that they read and read, give them people, ahead of time they go through it. When we also go through it, we come and examine it. But we had an experience that we meet up with some participants that they can't read and read, and some of them can even understand English except you read it to them and you explain. You have to find somebody to kind of interpret to them what you mean, and after everything they sound, that person also sound, then go ahead and sound also.
Thank you so much. So Anthony, you talk about confidentiality. Did you use any tool doing confidentiality? Can you share that with us?
Yeah, during the process, the confidentiality, I use phone and the consent form. And in keeping that confidentiality, I will take a photo and the person's face will not be there. Only the part of the body which is the problem or the disease condition is.
Okay, so thank you so much. Now, would like for you to share your personal experience of interacting with participants. Okay. In that case, it was like we interacted with one participant and we had our participant of state healer before entering the fence, their fence, except as a lady he used a laptop with hater. As he won't enter there and we were forced to go by their culture and respect their culture until we left from there. But she was somebody that always used to take pictures that we knew. And she always used to be open, always used to be happy to meet up with the team.
Yeah, in sharing my experience, and after my training, I got to the community and I did my community entrance with the town chief. I told him and the community welcomed me and the community was able to work along with me. Even in our community, when I explained the role and responsibility, people used to come up and engage me and say, come and see the condition and the disease condition. So it was very interactive.
Thank you so much. We appreciate you for sharing your experiences as co-researcher. Thank you.
Thank you.
Well, thank you, Hannah and team. With that, I just want to say thank you for all the presenters. And please continue putting your questions in the question and answer chat. I just would like to just say something about the whole presentations that we saw today. As a community health worker, I was really excited to hear about the programs that are being developed and implemented around the world. But today, just listening to what everybody is doing and looking at the role of community health workers as research, as part of the team, has been really long waited. I believe that when I began in the early 90s, we began educating the community, but we were not engaged as part of teams. Now we can see the community health workers are part of the team. They're being involved, but more than that, they're being provided the capacity and building their empowerment to be able to be part of the actual team that goes out in the communities and provides the services our community are needing. I am really impressed and really glad to have learned about how community health workers are helping treat your infections, your diseases, how community health workers are working around stigmatizing of disease conditions. And I believe that it's so important not to forget the community health workers. We have a lot of experience, but we also have the passion and compassion to continue providing support to all the programs that come into our communities. As part of the, I believe that I'm part of the Arizona Community Health Worker team that has worked with the University of Arizona in community-based participatory research since they began here providing that service. And I believe that they've always treated me with that respect and that knowledge that I bring the community focus, the community knowledge, but I have the trust because of the partnership, the collaboration that we've had for many years to allow them and to let them know when they are looking at my community from a 35,000 feet perspective, and so I can actually be able to provide the experience as I only can as a community health worker, because I am part of that community that is being served. I am part of the solution, but I am also part of the challenge and the barriers that I can see every single day. So with this, I am really excited that my colleagues, the CHWs working in Africa and Siberia, are really focusing on that important aspect of bringing the experience of their community within their core competencies they are providing to their communities when they're serving them. I also want to ask Dr. O'Donovan if he can actually talk a little bit on the questions and answers about his slide. You talked about the levels, level 1, level 2, level 3, level 4, And that was really interesting to see how you put it into an arrow going up. And what were the steps for you to be able to develop that? What was the training? Well, how was the CHW involved in the development of that training, and how CHWs were involved also allowing you to understand when they were ready to move to the next level themselves. CHWs were not only that CHW promotora that I began in early 90s, providing the education, but we're also part of the team that's now bringing the solution, bringing the information, but also gathering the data that will provide more opportunity to develop other programs that can actually influence and really address the needs and barriers and challenges that our community face. With that, please continue putting your questions and answers for the question and answer section right now. And I want to really say thank you for allowing me to be part of this. And we have about approximately 25 minutes for questions and answers, right, Rebecca? And Rebecca will be moderating those questions. So please, with that, I just want to say thank you. And Rebecca, I turn this to you.
Great, thanks, Floribella. We have a number of really interesting questions. I'm wondering if you want to give James a chance to answer the question that you raised in your summary. James, do you want to try and answer Floribella's question?
Hi, Floribella. Sure. Do you mind just asking the question again? Sorry, I was trying to find links to various papers to help people.
Yes, and in your presentation, you had a slide where you actually had an arrow and you said level 1, level 2, level 3, level 4. So I was wondering how CHWs were involved in the development of those steps, and when were they able to provide you information to allow you to understand when they were ready to move to the next level, or how did you design this slide?
Sure. Thanks for that question. I think it's really important. Just to clarify, the initial training workshop was held over a period of 2 to 3 days. The community health workers were trained in the recognition and management of ear disease in the community. And that was initially decided through a workshop planning process where some community health worker supervisors and community health worker leaders were involved. And in that workshop, we tried to formulate how the workshop should be delivered and how it should be assessed. And then the community health workers went out into the community. The diagram, which had the arrow showing level 1, 2, 3, and 4, was specifically in relation to how patients who were identified in the community should be subsequently managed. And so, for example, level 1 would be simple, basic management in the community. And that's where a community health worker felt confident enough to say, I've looked inside this person's ear. I don't think that there's a major problem going on. And also, in addition to the clinical history I've taken, I don't think there's a concerning factor. So I'm going to safety net, give that patient in the community some advice, and that's fine. They could also notify their own supervisor and say, I think this patient is okay. I think that we don't need to refer them up to level 2 or 3, which would be then to get the patient to come to the local health centre to be assessed by a clinical officer. Level 4 and 5 were more specialist referrals. And so level 5, which was almost the top level, was when the community health worker would go into the community. They'd maybe see a patient who would say, I've had discharge coming from my ear for the past 3 months. It's extremely painful and I can no longer hear. The community health worker looked inside the ear with one of their otoscopes and saw pus or discharge coming out of the ear. And then when they did the crude hearing assessment, they couldn't hear what the DSS was saying. They then refer up where the ENT specialist would assess them. And the ENT specialist, who was usually a surgeon, would decide, okay, I think this patient needs to come and have surgery at a local centre. And again, this isn't to say that this was a perfect process. There's issues with getting the patients to go from the community and travel to some of the major surgical centres, which are often in urban areas. There's levels of distrust where people don't want to engage with the formal health system. And there's also cost barriers, which are important to look at. And so one of the things that was proposed by the community health workers, once they identified this small percentage of very sick patients, was to say, look, we know that the patients aren't able to access the formal health system in the capital because of these issues. We need to bring the surgeons and the surgical centres into the villages, and we need to have surgical ear camps. That's something that's been done in countries such as Nepal. But again, it's a process that involves lots of different actors within the system, and trying to bring them all together is something that's extremely challenging, and something that Alan and Rebecca have experienced firsthand. So hopefully that answers the question. And again, this was all directed by the community health workers, trying to find out what they felt confident with and what they wanted to manage.
That's great. Thank you, James. We have another question.
Thank you.
Here.
It was very helpful. And
Great. We have several other questions, and I want to direct one to Kira. Kira, we have a question from Maris Koch, which asks, in the scoping review, and again, we heard a lot today about photo voice. So in the scoping review from the US, was photo voice also a method used? What other types of participatory methods can be used with CHWs as research partners?
So thank you for the question. I don't recall coming across photo voice in the intervention studies that we assessed, although I am aware that photo voice is being increasingly utilized within the United States. It just didn't really come through in the scoping review. In regards to other participatory methods, I think I can also speak to just some of the things that we do at the PRC that are participatory in nature. I think Flora can also attest to this too a little bit, but I think some of these things demonstrate how CHWs are involved across the research phases. So certainly with focus groups, during my time with the PRC, I've witnessed CHWs conducting focus groups, and also being part of the data analysis of focus groups with participants regarding their experiences with the intervention, things of that nature. Also needs assessments, which I know came up from other folks. So using needs assessments and surveys to identify community needs. CHWs have also been an integral part in that effort. And also something that I think is maybe less obvious to folks or researchers sometimes is the collaboration with community health workers in quantitative data analysis. So I have also, as part of the PRC, there have been instances where we'll do a particular quantitative analysis, but then also take it to the results to the community health workers and present these results and say, oh, does this pair with your on the ground experience? Did you observe this specific effect, or did men seem to benefit from the intervention more as opposed to women? And then they validate that finding, which I think helps eliminate the possibility that maybe it was kind of like a more spurious statistical result. So I think there are ways to make each phase of research participatory. Hope that answers the question.
Great, thank you. We have, next question is back to James and his colleagues. We have 3 questions around the same topic. And actually, I think it's a really interesting question in general. We have a question from Romney Redman. Was the topic of ear care prioritized by CHWs as well? And we have a similar question from sort of Henry Perry, which is, we have one presentation on childhood ear diseases in the community and one on skin diseases. It seems as if one interesting line of research might be for CHWs to identify neglected but serious health conditions that they come across in their work in the community. Are there articles on this type? I'm not aware of any. And finally, Rachel Taylor also asked a similar question about what's CHW's role in sort of determining what the research questions are, or what topics to research. So I'll hand that over to you first, James, and then maybe Hannah and Rosie, you might also have something to say about this.
So I've typed in a written reply to all of those questions, and hopefully that has satisfied the people who've answered the questions or asked them. But In brief, yes, the topic of ear care was highlighted as a disease burden. That was done in the first Photo Voice project. However, perhaps Alan and Rebecca might like to just discuss very, very briefly about the other issues that were highlighted during that initial Photo Voice project, such as eye care, mental health issues, and access to clean water supplies.
Thanks, James. Yeah, so ear care was the major concern of the whole study. But as you know, in the communities, you always find other illnesses as well. So since we are all in the medical field, and as OmniMed, we have other areas that we work in. So we may be working on the ear, but still we get someone who has eye problems, and we've come across someone who are specialist who knows about the problem. So in most cases, we make referrals to those to the specialists. So ear care was the major concern, but other illnesses also came across, and we were advised immediately. Maybe if Rebecca can add on something.
Yes, like ear care was one of the major illnesses highlighted in the community, but that doesn't mean some others are not a concern. For example, while we were diagnosing ear problems, many people came up to ask us to also bring maybe opticians that can help with eye diseases. And also in the process, we also realized some other cases like mental health, and we actually noticed people had little knowledge about it. So much as we focused on ear initially, we realized that there are a couple of other illnesses in that area, only that it becomes really hard to focus on this and at the same time focus like on another disease, but there are definitely other illnesses. Thank you.
Great. And Hannah and Rosie, I don't know if you have anything else to say about this, but how was the subject of stigmatizing skin diseases determined, and did CHWs have a role in identifying that as an issue for research?
So
Yes.
go ahead, Hannah.
Yes, so like they are called community health workers. They are mostly in a community working with the different community people. And some of the different diseases, they usually come across it, they see them, and they know how they manifest with the different group of people in the community.
Great, thank you. So we have another question that I think is really important from Carrie Scott that I think applies to both James, the work that you did, and Hannah and Rosie and colleagues. And Carrie's question is, many CHWs are busy with their existing health promotion and curative work, and also other employment, farming, caring for their family, etc. How should we balance the benefits of CHWs as research partners with the fact that they already have a lot of other work to do and are busy? Should all studies start with the assumption that CHWs want to be research partners and involved at all stages of research?
So, yeah, go ahead.
I'm sorry.
No, go ahead, Hannah, if you've got something to say. I'm happy for you to answer first.
Yes, so I would just like to share something. The community health workers recruiting as participants or peer researchers is in line with the county health team. So in Liberia, we call it different county where we have the head of the county health team. So they are not just recruited from the community to work along with us, but they are in collaboration with the county health team. So we could look in that direction to see if they can work together to become a peer researcher or researcher in that way. Thank you.
So I think Kerry's raised a really great point there, and that's the issue that, again, we can't place too much burden on the community health workers. And again, it's different depending on the specific locations that you're looking at. So if a community health worker is a paid community health worker, which they all should be, ideally, then that's one issue. When you've got community health workers such as the village health teams in Uganda, where they're volunteers, you're asking an awful lot of these people to not only deliver care in their communities, but also live their own lives. For example, look after their children, attend to their crops, attend to night school, which some of them attend, run their businesses in the local markets. And so it's really important to take this and look at a systems level approach. And some great work has been done, I know, by Kerry and other people who are involved in the Community Health Impact Coalition. And I think it's really important that we advocate for all community health workers to be paid, but also really try and involve the community health workers at every stage of the research process. And most importantly, I think that's something that was really, really important from Kira and Maya's work in this scoping review, was try and get the community health workers involved at the very start of the research project and say, what is the issue you're facing and how do we best address this? So we're not actually placing more burdens on them. And so I think that that's something that's really, really important. And thanks for highlighting, Kerry.
Great, thank you. And just Kira, did you come across anything related to this issue in any of the papers that you reviewed?
Hi. So yes, I do recall a couple of discussion sections that did address, like James was mentioning, just the burden element placed on community health workers in terms of trying to balance, their existing roles and then also the research activities. But I think that there is also an intrinsic interest on the part of the CHWs to be a part of the research process. And of course, I mean, that's not to say that, there should just be the outright assumption that they're always available, but I just think by nature that community health workers have a vested stake in bringing, quality evidence-based tools and interventions to their community, and they have so much knowledge and insight into how to best facilitate that. So I think that there is that natural interest, but of course that the specifics have to be negotiated in terms of the partnership between the academic partner and the community health workers.
Great, thank you. Another set of questions we have that came up from more than one participant are around the issue of how community health workers build trust. And I know, Alan, you and Rebecca had mentioned that sometimes when you went into the community to take photos, people were uncomfortable with this. And so we had two participants ask, how did this community health workers in collecting data in the community, how did you go about building trust of community members? And then we have another participant that asked along the same lines, in doing this research, did you ever feel that the concern of community members was at a level where you actually felt threatened in doing this research, that you felt like you were in an insecure position and even asking for information or taking photos? So maybe I'll open that up for Alan and Rebecca, and then maybe Hannah, you can find out if Sata and Anthony might have something to say about that as well.
Okay, thank you for that question. To begin with the first one, the community health workers try to build trust with the people in the community by fully explaining what the project was about. And also we introduced some papers that were translated in Luganda, the language they understand best. And in those papers, we fully explained what the whole project was all about. And we were asking for their permission, which kind of made it official, because they were like, yeah, at least I'm not signing somewhere. So that kind of helped build their trust. And the community health workers tried to befriend them. They were like talking to them at a personal level, which also kind of helped to build their trust.
Great, thanks, Rebecca. Hannah, anything to add to that?
Yes. So with regards to the issue of trust, the community health workers, some of them, they are nominated by the community leadership. So they already have trust in them. they already know their capacity to lead them. So working around them is not a problem because they nominate them and they have built rapport with them in a different community. Thank you.
All right, thank you. I'm going to be mindful of time. I'm going to ask just one more question, and then I think we'll have to wrap up. There are other questions, and we'll try to get answers to all of them if possible, and share them with folks that attended today. The last question I wanted to put is posted by Annette Ridd, and it's a really important and interesting question. And she says, thanks again for a great set of presentations, which highlighted the important potential of CHWs as research partners. In your experience, what challenges, practical or ethical, do CHWs face beyond those related to specific technologies like photo voice and time pressure that have been mentioned? And actually, I'd like to put this to Kira first. Kira, were there ethical considerations in terms of CHW's participation of research partners in the systematic review you did that are important to highlight?
So I think I recall one specific ethical consideration, not so much in terms of the inclusion of CHWs within the research, but I think ethical concerns that CHWs brought to the research team. And I think this specifically had to do with the use of randomized controlled trials, so potentially withholding an intervention from a particular group. And some CHWs were very concerned about that, about explaining, that to participants and what that could potentially mean for the acceptability of the intervention. So I think we saw that land in two different ways, where the first option being that CHWs did explain that, it's important in terms of determining, the effect of an intervention, that we have a control group, things of that nature. So CHWs did take on that responsibility of explaining that to participants, but also there were instances where, withholding an intervention within a community just really wasn't practical. And then academic teams needed to respond to that and potentially reconsider their study design. So I think it's important if CHWs do raise that ethical concern that it's, something that's an active and collaborative discussion, and, not just assume that even though RCTs are considered, kind of a gold standard of research, that sometimes within a community that may not be feasible or practical or could really impact, community residents being participants. So that was one particular ethical concern that I recall from some of the studies that we reviewed.
Great, thank you. James or Hannah, anything else to say about the ethical issues before we wrap up?
I don't have anything specific to add other than I've shared some links to some important papers which focus on ethics, specifically pertaining to photo voice, but also participatory visual methods more broadly. It's a very rich topic of discussion, and it's also an important area to focus on. Ethics and the role of research with community health workers more broadly is quite underexplored, but something which I think we should be focusing on as we move forward in the next few months and years.
Fantastic. Florabella, we're at the hour. I'll hand it over to you to wrap us up.
Thank you, Rebecca. And this concludes our today's webinar, Enhancing Community Health Research by Engaging Community Health Workers as Research Partners. And I would like to thank all the participants and the speakers today, my colleagues, the CHWs that presented. And of course, I want to also thank the Health Systems Global Thematic Working Group on Community Health Workers, the HSG Social Science Approaches for Research and Engagement in Health Policy and Systems, and CHW Central for Arizona for organizing this webinar. I also want to remind you that this presentation and the recording will be available in the CHW Central website. And of course, thank you so much for attending this this presentation. Thank you to the speakers that were able to stay and respond to all the questions that we had. Thank you everybody for attending today. Have a great day.